criking is like getting to the decision that you need to crike. I think once you get to the decision, then most people do fairly well with this. There are a variety of techniques. The technique that I'm most fan of at this point is to essentially make a long vertical incision. So if you have the foresight to think this might go poorly, find your landmarks and mark it with a Sharpie. That makes it a lot easier. But if you don't, I'm going to make a long vertical incision, and I'm going to have something to dab because I'm going to although this tends to be a relatively non-vascular area, not everybody reads the anatomy books, and if you have bleeding, I'm just going to dab and hold so I can see. And then I'm going to kind of gently spread the tissues apart to hopefully find the cricothyroid membrane. If I'm able to feel anything, I'm going to put my marks, and then that'll help me reference. But a long vertical incision, dab, spread the tissues open. As soon as I find what I think is the cricothyroid membrane, I'm going to do. Ideally, I would like that short, narrow stabbing blade, the number 11. Your kit comes with a number 10. I'm going to stab straight down where I think the cricothyroid membrane is and go to the side. Now, you probably think, oh my God, am I going to go through and poke something in the back? That cartilaginous base is actually extremely robust.
We've played with it in the cadaver lab where we have the scalpel and we're poking that posterior portion, and it's nothing.
So what you want to do is go down and in, and then go to the side, and then in the real cadavers, I was not able to flip the blade around. I had to pull it most of the way out where I could flip it around and then complete the cut the other direction. And then they want you to get your finger in there to mark the hole. And I'll tell you what, I couldn't get my finger in there. So the short bougie, and remember you need to make sure you're going down. And essentially I'm just going to stuff that bougie in there until it stops. On real people it tends to, so on these mannequins it tends to go straight out, go forever and ever. On real people it tends to stop at the carina pretty nicely. Let me pull that off for me, and then the paper. And then we're going to just follow over. This tube you have here is actually really nice with the little.
Yeah, because the way we do it, I think Nikki recently, she picked up a cric not too long ago, and they were right main stemmed. Because if they're just using an ET tube, because we're essentially below the vocal cords at that point when we're putting it in, so you don't have to advance it if you just had an ET tube. With this, it automatically stops you. Super easy to right main stem. Technically, you could do it with this too.
Yeah. Once you get the balloon in there and can inflate it, that's really adequate. This stop is kind of nice for yours here, although the tube seems really stiff there. Oh, maybe it's because I have that's
still pretty stiff.
That's pretty stiff. What we would do is we're going to use a 6.0 ET tube. The 6.5 is pretty close, and essentially we probably want to be able to see the black band and have the balloon in there. But in the excitement, it's so easy to, who wants to put it in just enough? And then for our protocols, what we do is we deliberately do not cut the tube off so that people know what's going on with it, because you never know who's going to see this next or what they're going to think.
Plus you don't want to cut and be able to not inflate your balloon.
Yeah.
Yep. Cut the right
Yep. Yeah, so, yeah. Your helpful person is not paying attention will cut here, then you don't have a balloon anymore. Even this is still fairly long. So that's our... So recognize that once you put this in, that you're at high risk of right main stemming. So really make sure you're neurotic about, once you get this secured, to listen to the breath sounds. And you can slowly pull this out. That's okay. I think you're... I guess some people would want to use this and just kind of spread, but...
So is that for when you're cutting, then you insert your tongs and spread?
So this is designed so that you can hook and pull to the side or something like that. This you can do like a blunt dissection.
Yes,
Once you get your knife blade in there, you can kind of open it up. But what I think I would recommend, and based on what I've read,
Stab one side, turn, come back to the other. Put your finger in.
if you can get your finger in,
if you can, great, yeah. If not, throw the bougie.
Yeah.
Okay.
I was not able to get my finger in a cadaver ever. Like, it wasn't even close.
I can talk to, like, some of that tissue will move around. Talk to some guys that have criked, and this tissue right here will move around, and they're getting their finger in there, and it's just kind of moving around. They really can't get that in there, and then it just keeps keeps moving
So
around.
this tissue absolutely will move, and you absolutely will get false tracks.
Mm-hmm.
And especially if they have neck trauma, like, what a mess. So
Something else you can do to identify your landmarks, or once you get your landmark, you can act as if you were going to needle crike the patient, get a 14 gauge, find your landmark, stick it in, then you have that landmark in there and cut alongside your 14 gauge.
I like that. That's a good one.
But for what you're saying, don't ever let, once you have made the cut,
Don't let it
something
go.
has to be in that hole, whether it's a bougie or your finger, or if you're going to stick your hemostat in there.
Something in there, yeah.
Yeah, because people with trachs, until they mature, this is just an absolute disaster if the trach comes out. Because the tissue planes will move, and you'll never find it in a million years. You're just like
You get to be on the
totally
cut, right? I
screwed.
mean, yeah.
You're so screwed. Yeah. So, yeah, that's what I would say to you. Once and like, seriously, like, trying to just get your finger in there, like,
Mhm.
I mean, this is a rigid ring. I can't get my finger anywhere close to being in there. I don't know. What does anybody want to add? Any questions?
I think that's spot on.
So, I would like to just emphasize a couple of things. When we're doing this, don't worry about the cosmetic result from a long vertical incision. We decided to do this to save their life. Not only that, fixing a surgical scalpel incision is really easy. Right? I mean, like, this is
It's not
easy
a
to
rigid
fix.
cut, exactly.
Yeah,
It's
yeah.
a
This is
heel.
not like, you took the skill saw and ripped
No.
half the tissue away or whatever. Yeah. So
No, it's a surgical procedure.
so cut a longer vertical line than you think you need, because the last thing you want to do is make it too short, and then you're trying, it's not quite long enough, and then it starts to bleed, and what a mess.
One thing with cutting, can I see that
Oh,
really
sure.
quick? Our medical director, we're not professionals. We don't use scalpels on a regular basis, so you obviously see them cutting like that. Hold it like a pencil, just so you have more control of the blade as well.
And I'll tell you from my time in the operating room and from the one finger thoracotomy I've done, I'm actually a fan of doing a more gentle incision and coming back and making it a little deeper rather than trying to
Go for the
slash. I mean, you can very quickly cut again and kind of spread the tissue, but get something in your hand to dab it with. Just hold it for a second, spread and look and make it a little deeper. But yeah, holding like a pencil, you have way much more control. I feel like there's you should clean this. What do you have to clean tissues?
iodine
Iodine? Okay.
and alcohol. So
Okay. Do you have chlorhexidine by any chance?
No, just
Okay.
iodine. Yeah.
Okay. Chlorhexidine is hands down the preferred thing if you're going to make an incision. There was a great study, circa, I'm trying to remember, not very recent past, that looked at like all kinds of surgeries in all kinds of different hospitals. And if they prepped with chlorhexidine, the rate of infection was drastically decreased across the board in every setting, in every surgery. And you can get them in those little freps. Who's your supplier? Are you using Boundtree or who are you using?
No, Life Assist is typically what we're
Okay.
going through.
Okay.
Yeah.
They usually sell those little fraps. I don't know if that's something you'd be interested in.
Okay.
I mean, I don't know. Infection is probably not a huge concern if you actually have to crike somebody, but to get an infection, it's nice.
Something else that they've been talking, I've never seen it done, but if they're a bleeder, if they're bleeding a lot and you just can't see your landmarks, you can use soaked epi gauze to kind of pat around and hopefully vasoconstrict a little bit. Yeah.
Constrict a little bit.
Yeah.
Absolutely.
If
I would
you
probably take the 1 to 10,000 and just squirt on there,
squirt on it, yeah.
and then hold it with the
Use
rag.
A nasal atomizer.
Yeah, that's what I was thinking too, an
Yeah.
atomizer.
Well, that's what they use in the OR. Is they use the giant epi bag. Kinda, right?
So pretty much we would never make this kind of incision with a scalpel. We'd use a bovie, an electric artery, so that cuts and coagulates at the same time.
Oh no, but I'm just saying, like for the epi, for the purposes of the epi, like you said,
Pressing the
like the
vessels.
pressing
Yeah.
the vessels, so there's not as much.
It's in an operating room, it's usually going to be the electric artery more than now certainly, if you start having a bleeding problem, then we've certainly used epi, and we have a variety of other hemostatic agents, gel foams and Arista, and there's dozens of things that are pro-hemostatic agents that you'll use. We have some glues and.
From an ACE inhibitor anaphylactic reaction. So we're just going to really do airway instead of talk about pharmacology as well. But you guys come into this guy,
And he's just
right, tongue is swollen, face is swollen, eyes are swollen. You guys attempt to get in there. Now he's altered. These are his vital signs right here. He's starting to trend down on his blood pressure. So he's hypotensive, hypoxic. What would you do for him?
so start a line. We've already tried to get it back once, and that's not going to work. So let's get a line going to support vitals. Maybe give him a bolus to keep the pressure up.
Cool.
Make sure let's get all his vitals. Make sure all his vitals are kind of normalized before we try to do anything drastic.
Okay, and his sat just keeps dropping. You can't do anything. You're bagging him now.
We're bagging. We can't get a simple airway.
Yeah, you put. At this point, the OPA won't fit in.
Okay, and
And
NPA.
angioedema. OPA, NPAs you got in there. You're bagging still.
It's just nothing.
Yeah.
The back compliance is crap.
Yep.
Okay, well then,
You're getting minimal chest rise and fall, and you're now you're at 79%,
okay.
75%.
So at this point, we have no way to effectively oxygenate the patient in traditional terms, even with the end tidal.
Okay.
So we'd have to go with cricothyrotomy.
Okay, so on this patient, let's see, you can't feel. So your cricothyroid membrane, of course, starting from your Adam's apple, right, coming down.
So you're coming down here, you feel, and you're looking for that little gap.
Perfect.
You're feeling for that soft spot.
Okay, so I'll move this off, and then you'll just, your partner's going to set you up for success, so you're going to tell him what you need as you start busting out.
Okay, so we have the cric kit. I'm gonna need our cric kit ready to go. Okay, tricky in the bag. Okay.
So he already opened it up and things are all over. There's already tools all over.
Okay. Everything's everywhere.
As a real life call would be, right?
Right.
So here's our bag. We got where's our cric kit? So where's the little tiny bougie? Because it would be all together.
Hey Keith, do you know where the? Oh, here it is.
I thought I'd stack
Sorry, it's right there. Patrick.
It's all over the medic.
All over the medic. So, scalpel.
I think the assistant moved it all over and threw it on the ground.
Spit on it. Yeah.
I don't know what this is for. We probably doesn't need that.
Okay.
That looks sharp. Let's get rid of that before he hurts himself.
So for me, I like to kind of cut my spot before I'm gonna do anything.
That's all in
So
there.
here, here. Take this off. Put this to here. Profile. This down there. Okay, so this guy's gonna be right here. Yeah. Like this. I'm gonna take this out.
Yep.
Somebody have scissors or a
Smell?
knife or a sharp object of any sort.
There we go. A nice knife. Oh, wow, that's right. Really stings the nostrils. Okay.
Let's set that on the
Oh,
porch.
yeah, I just got that. Woo.
Do you have like a baggy clip or a
Let's see.
ziplock or?
Where'd you get the gloves at? Oh, here you go.
So I feel like that's probably
There we go, right here.
Yeah.
So we got it. So I'm filling down at the hard point. Boom. Here we are right here.
Yep, and we always do the laryngeal, what do we call it, handshake. So you always want to remember stable drink
Stabilize.
with one hand.
Okay, so right here.
Okay.
Doesn't really matter if I'm covering his
Are,
mouth.
are you a righty or a lefty?
I'm a little bit ambidextrous.
Okay.
So,
Your
where's
knife is here.
Thank you. So, like you said, pencil,
Yeah.
right?
So you got to push down on the little tab, and then it'll come back. Push down here,
Oh, there we go.
and be careful because if you're not
Really
used to
sharp.
those, yeah, it'll like go right through the palm of your hand. Not that that's ever happened to me. So pull it all the way back until it
Oh,
locks.
pull all the way back.
There you go.
Oh, okay. Right here, double check my spot. So you said
Now, as your
stab.
partner, you want him to hand you
Yeah.
stuff.
So the technique I would do is a long vertical incision and spread the tissues
Okay.
so that I can find it easier. I'm not sure how well this is going to really spread. That looks like really.
So we'll do another one, like you said. There we go.
I don't know if like.
There it goes.
Wow, this is really
Okay.
fibrous stuff here.
So then you said now come in this way, right?
Mhm, straight in the middle, all the stab all the way down, all the way down. Perfect.
Okay.
Go to the side.
Come this way.
Yep, and then
Now.
flip it around. And now you need to get something in there.
Now the bougie assistant. Thank you. There it is. Okay, so we get the stop
And
there.
when you
so
see it
that's-
come out of the trachea that's disrupted at the bottom.
Yeah. This is all I'm working on right now. So I got it. Alright, so this is coming through here. This is coming through here. There we go. So that stops that for me, which is pretty neat.
I would cover your blade.
Oh yeah, thank you.
There you
Sorry
go.
about that.
No worries. That's
So the inflate. Right there. Yeah, that's good.
and so I would have my end title on here.
And okay, and title. Are we worried about PEEP?
Yeah, I mean,
Honestly,
I would
honestly.
have PEEP on there, and then I would also have, once again, your HEPA filter.
Yeah, okay.
Yep.
So filter, peep, and then I'd have my end title.
Okay, and then we just secure this.
Yep.
And then clean up. Okay. Now what am I looking at? What are my vitals coming
Oh,
back to?
they're good now. They're 95%.
Oh, perfect.
Your
I'm looking for
pressure's-
missing the two. I'm looking for my entitle to come back up to range of 35 to 45.
So that's just a Velcro to go around.
Hopefully
the
the
neck.
bowl has helped with the pressure. And sorry I had to cut a hole in your neck, but you're alive.
Right.
So for something like this, when you kind of see it go in, as soon as you see that square end title, like that's just so golden. Now I'm not saying you don't do all the rest of the stuff, but I think that that nice square waveform capnography,
Yeah.
and you'll see that on breath one.
Yeah.
Like on breath one, and you're just like, okay.
This is cool.
I love the tears I've dropped to be part of the wave. Can't stop, ever wonder if it